This is an interesting and quite a complex case involving an 8-year-old male patient who presented with the primary complaint of an unerupted tooth, specifically tooth 1-6. The patient had a medical history that included asthma and environmental allergies, but was otherwise healthy. Notably, the affected area was asymptomatic, showing no significant soft tissue swelling, erythema, or purulence. A panoramic radiograph was taken, revealing tooth 1-6 as unerupted, with more than 2/3 of its roots developed and the roots showing distal delaceration. Distal delaceration refers basically to a curvature or bend in the tooth root, which can complicate the eruption process. Importantly, there was no evidence of external resorption of tooth 1-6 or the adjacent teeth, which indicates that the unerupted tooth had not caused any damage to itself or nearby teeth. Additionally, teeth 2-6, 3-6, and 4-6 had erupted normally for the patient's age, highlighting that the eruption issue was isolated to tooth 1-6. To address this, tooth 1-6 was surgically exposed, and during the surgery, expanded buccal bone and a pericoronal soft tissue mass were discovered. This mass was excised and sent in 10% neutral buffet formalin for histopathological examination. The tooth was luxated to assist with its eruption. Microscopic examination of the biopsy specimen revealed multiple fragments of tissue composed of islands and strands of odontogenic epithelium mixed with immature, blunt mesenchymal tissue. Some areas of the epithelial islands showed peripheral columnar cells with palisated nuclei, cytoplasmic evacuation, and central areas resembling the stellate reticulum. These findings are significant because they are characteristic of a benign odontogenic tumor. Importantly, there was no cytologic atypia, necrosis, or significant mitotic activity, confirming the benign nature of the tumor. And so the diagnosis of ameloblastic fibroma was made. 3 years down the line, the patient returned, and unfortunately, tooth 1-6 remained unerupted. A new panoramic radiograph showed the tooth in a similar position as the previous image taken 3 years back. Additionally, a periapical radiograph revealed multiple small flecks of radiopaque material around tooth 1-6 and distal to tooth 5-5, the primary tooth. This suggested possible changes or developments in the surrounding tissues. Another surgical exposure and excisional biopsy were performed, and the specimen was again submitted in 10% neutral buffet formalin for histopathological analysis. The surgical biopsy revealed a single cystic lesion lined by non-keratinized odontogenic epithelium with a fibrous connective tissue wall, including areas of primitive connective tissue. Within the wall, there was a well-defined, non-encapsulated proliferation of odontogenic epithelial islands and cords with basal palisading, surrounded by moderately cellular primitive mesenchymal tissue. There were also focal areas of hyalinization and calcification, along with melanin deposition within the epithelium. Importantly, again, no cytologic atypia, necrosis, or increased mitotic activity was observed. High-power evaluation of the cystic lining showed that the basophilic palisading odontogenic epithelium component sitting in the cyst wall was present at the cyst lining. Numerous areas showed epithelial islands connected and directly originating from the basal aspect of the cyst lining. The final diagnosis that was made was cystic ameloblastic fibroma, a variant of ameloblastic fibroma with obviously cystic features. This diagnosis is significant as it underscores the importance of thorough and ongoing evaluation in odontogenic lesions to ensure accurate diagnosis and treatment. To date, as per the paper, the patient remains asymptomatic with no evidence of recurrence, highlighting the effectiveness of the treatment and the importance of regular follow-up. This case emphasizes the need for careful diagnosis, appropriate surgical intervention, and consistent monitoring in managing complex odontogenic lesions.